Okay, I think we're live, and we're going to start this first Facebook Live presentation for House Ear Institute. Hopefully you're able to see us online. So looks like we have a signal and we're broadcasting, so we are live. Today, I'm Dr. Eric Wilkinson. I have Dr. Edward Ted Cho with us today, and we're broadcasting from the House Ear Institute here in Los Angeles. And our first HEI live presentation is on balance, dizziness, and vertigo, which is a very broad topic. Before we begin, I wanted to just mention something about medical informational presentations such as this. So I'm going to read from our Facebook page, and it's the following. It says, House Ear Institute may from time to time present informational sessions on medical topics via social media such as Facebook, YouTube, and other social media outlets. These informational sessions are for informational purposes only and should not be considered medical advice. These informational sessions are not intended to be a substitute for individualized medical advice, diagnosis, or treatment by a physician who is aware of your medical history and has had an opportunity to examine you. Do not rely on any informational sessions presented via House Ear Institute social media in place of seeking professional medical advice. And certainly for something such as new dizziness or new vertigo, this is particularly important to have your physician examine you and do a thorough evaluation. So today, Ted is with us, and I want to just give Ted a chance to introduce himself, a little bit about his training and his area of interest. And so Ted, why don't you go ahead?
Sure. Thank you, Eric, for the introduction. So my name is Ted Cho, and I'm trained as an otolaryngologist. I did my training at the Cleveland Clinic in Cleveland, Ohio. And after my training in otolaryngology, I did a one-year fellowship in vestibular and balance disorders. So essentially learning on how to diagnose and treat individuals with dizziness and balance disorders. I practiced in Cleveland, Ohio in general otolaryngology for a few years, and then I was recruited to come here to the House Clinic in 2013, where I've set up a dizzy and balance practice and see patients 5 days a week at various locations, primarily at our Los Angeles site, but then on Fridays at our Orange County site. And we have a wide array of tests and diagnostic procedures, and I work with many physical therapists in the community in order to treat these vertigo and balance problems.
Great. Thanks, Ted. And just to introduce myself a little bit, I'm Eric Wilkinson. I'm one of the neurotologists here, and I do see medical and surgical patients with dizziness and vertigo. But I'm so glad to have Ted in our practice because he's really a doctor's doctor in terms of this area of specialization, and having him to consult with and send patients to is invaluable for us. We are fortunate to have him. So I think what we'll do today, we have some people watching, I think, online, and we'll be able to have some questions if people want to put those in. We have a couple of our own to start with, but if you have any questions, you can certainly post them on the comments. We have a couple people commenting, so we know we're running okay, and our audio is fine. So what we'll do is one thing I wanted to ask Ted to start with, which is I think a common question is, can dizziness ever be completely cured? And I guess to some degree it depends on what it's from, but Ted, do you want to comment about dizziness generally and whether it's something that we can cure or fix?
Sure. As Dr. Wilkinson, Eric was saying, really depends on the diagnosis. There's a wide range of types of dizziness, most common being Bppv, which is related to crystals that are loose in the inner ear, to other inner ear issues like Meniere's disease or even vestibular migraine, which is a form of migraine where you may or may not get headaches. It really does depend. I would say in general, I typically counsel my patients that you think about dizziness and balance disorders as more of a chronic condition. And so I usually compare it more to something like high blood pressure or diabetes, something that can definitely be controlled with adequate dietary measures, physical therapy, medications, even surgery, but likely something that you'll always have to watch out for, and something where there may be some flares in terms of symptoms. That being said, there are certain types of dizziness, like vestibular neuritis, which typically comes from a viral source, or even something like Meniere's disease, which if treated, if you need to treat it with surgery, you can definitively cure the dizziness. But I would say, for the most part, I tend to treat dizziness as a chronic condition, except for certain specific types of dizziness syndromes.
One question about other specialists or people that you involve in both the diagnosis and treatment of dizziness. What are other medical specialties or other healthcare individuals that you get involved in this? Who do you call on for help with diagnosing and treating dizziness?
Yeah, that's a really great question. And I think one of the most important things about the management of dizziness is that it is truly multidisciplinary. You do need people from all different areas, all different fields. They're not even all medical doctors. And so I would say, in terms of at a balance center, the typical team that you work with include physicians, MDs, like myself. There are some medical doctors who are specialized in the ear. They're called otolaryngologists. I'm one of them. Dr. Wilkinson, Eric, is one of them. There are neurologists who are good at treating some of the neurologic forms of dizziness. There are non-MDs like physical therapists, and I find that physical therapists are individuals I rely on to help with the rehabilitation and treatment of things like neck-related cervicogenic dizziness, or repositioning some of the more difficult cases of Bppv. Audiologists are indispensable as well, because they're involved in the testing, the hearing tests, the inner ear balance tests, a wide range of ways of assessing the vestibular system. And then of course, there can often be anxiety or other social factors involved with dizziness, and so it's not uncommon to elicit the help of psychologists, psychiatrists, particularly working with primary care doctors, and so it is a fairly large multi-team approach.
Great. When you see someone with dizziness for the first time, what kind of questions do you ask them about their symptoms and their problem to get at where the dizziness is coming from? What are the general things that you ask when you first meet with someone?
Yeah, so history is so vital in terms of diagnosing dizziness and balance disorders. My mentor, Dr. Judy White, who I worked with originally at the Cleveland Clinic, I think she had said that about 70% of the time you can diagnose most dizziness and balance disorders just based on a good history alone. And so I usually start off with a fairly basic narrative. Start at the beginning, tell me about some of the episodes. Specifics are really important. Duration. I often ask people seconds, minutes, hours, because that can be a very key factor in determining what the underlying cause is. Another important question or answer to have is, what do you mean by dizziness? Dizziness can mean a variety of things to a variety of people. Vertigo actually means spinning. So if somebody says you have vertigo, they're not really diagnosing you with anything. They're essentially saying you have a symptom that involves spinning. Another type of dizziness symptom people often describe is rocking, swaying like they're on a boat. Another type is lightheadedness, very common if you have low blood pressure. And then final is just imbalance. Some people just feel dizziness when they're walking. They feel very unsteady, like they're going to fall, not really spinning. And so these are some of the important questions. Essentially, if you boil it down, it's like the who, what, when, where, how, why. I mean, if you have answers to all those questions, I think you've come a long way in the helping your physician come to a diagnosis for your condition.
Great. I think it was William Osler, the famous physician, who said, listen to your patient, he or she is telling you the diagnosis. And I totally agree with you that history from the patient in this situation is critical. And I think sometimes it's easy to jump to examination or testing results and try to do things that way. But in dizziness, going back and sitting with the patient, having them explain what's going on, typical spell, typical way things manifest is key. And I think that it's funny because when I do this, many times a patient will tell you within the first minute or two what the diagnosis is, and then it's just a matter of confirming or refuting what your suspicion is. And we call that differential diagnosis in medicine and trying to narrow that down. But in this case, the history is critical. And sometimes I think we see patients who have had a number of tests done. People will bring in a lot of different tests, and it will suggest a certain thing, and they'll say, my doctor said I have this because of this test. And that can confuse things because people come in with presuppositions about what their diagnosis is, and then we have to lead them through and go back to the beginning. So just another question. I know a few years ago we started learning about migraine, and for many years I think it wasn't clear that migraine could be such a large contributor to dizziness and vertigo. And when I was finishing my training, I remember some panels at some of our annual meetings of our specialty where the pendulum was really swinging towards migraine being a big factor, and people thinking that migraine was a contributor in many, many kinds of dizziness. How much does migraine contribute? How much does it overlap with other things that you see, such as Meniere's disease or benign positional vertigo with the crystal problem you mentioned? How much does migraine tendency overlap with other forms of dizziness that you see? In other words, how often is there more than one thing going on, one of which being migraine or another kind of neural sensitivity of that form?
Yeah, that's a really great question. So in one of the talks that I give, I make mention of the fact that the association between migraine, dizziness, vertigo was known as far back as the 1800s, but it took all this time to really have it come into the medical literature. And I think some of the first studies were done in the 1980s, and then in the 2000s, groups in Germany in particular came up with a more formalized definition of vestibular migraine. Now, vestibular migraine has a specific diagnostic criteria, and it actually is in the newest edition of the International Classification of Headache Disorders. That's what your neurologists and primary care doctors use in order to diagnose migraine. And as far as vestibular migraine, it is helpful to have a migraine headache history, but it's not absolutely necessary. And we are rapidly finding within our dizziness community, the physicians in the dizziness community, that vestibular migraine is the most common cause of neurologic or central dizziness, and probably the second most common cause of dizziness or vertigo overall behind Bppv. Dr. Wilkinson brings up a really great point. Often there can be a significant amount of overlap between vestibular migraine and other entities. Studies have shown that individuals with just migraine headaches, maybe not even vestibular migraine, have a higher incidence of Bppv, which are those calcium crystals that get loose in the inner ear. So I think it's about a 2 or 3 times increased chance of getting Bppv with a migraine history. And approximately 50% or more of individuals with Meniere's disease either have migraine headache or they have some sort of migraine feature just in terms of their daily symptoms. And so more and more we're finding that there is a lot of overlap between migraine and Meniere's disease, which is something that otolaryngologists are very well equipped to treat. And so so definitely we're seeing that migraine or migraine tendency is extremely common, which is not surprising given the fact that migraine headaches in general are fairly common within the general population, particularly in women. Higher incidence of migraine headaches in women than in men.
Thanks. Yeah, it seems that the tendency for migraine, and this is one question I have about the criteria, because I know we have the criteria for migraine. It seems to me that the tendency towards migraine, or what I would call, I explain it to patients as a neural triggering phenomenon or a neural hypersensitivity phenomenon that can overlap with vascular or blood vessel issues in the brain. The tendency towards a neural triggering phenomenon seems to be incredibly common. And overlaps with a lot of these other things, and sometimes it seems that we are historically maybe a little bit too quick to call everything migraine, but it does seem in reality that it does overlap with many disorders.
Yeah, I think that's a really great point. In the world of dizziness, vertigo diagnoses, you have certain entities that have certain diagnoses, certain syndromes that have very clear diagnostic criteria, like Bppv, Meniere's disease, vestibular migraine, vestibular neuritis. And then you have a whole slew of patients who come in with symptoms that don't quite fit into a particular category. And I agree, vestibular migraine is one area where a lot of these unknown or unclear diagnoses have people can be labeled with vestibular migraine. That being said, even if it is not necessarily the most precise diagnosis at this time, I have personally found through patients that a lot of the migraine treatments, which not only help headache but help some of that neural sensitivity that Dr. Wilkinson is talking about, some of the basic migraine treatments can sometimes work for these other forms of dizziness if they don't meet, particularly if they don't specifically fit under the vestibular migraine diagnostic criteria. But that treatment can still be very helpful.
Great. One question that we get frequently from patients is, especially patients, for example, as they're getting older, they start having trouble with general imbalance. Many times they come in wondering whether the inner ear is the problem, whether the brain is the problem, and we come to a consensus that in many cases this is a multiple cause issue associated with aging. And we often refer these patients for physical therapy, vestibular rehabilitation, we call it. Now, and the question we get from patients is, does that really help? In other words, is this really going to help me get better? How would you respond to a patient who says to you, is physical therapy going to help me with my problem?
Mm-hmm. Yeah, so particularly for those individuals where as they age there's a deterioration of various balance senses, whether it's vision, some loss of inner ear function, some loss of, the term is proprioception, which means overall position sense, like you get numbness in your ankles, your knees, your feet. Vestibular physical therapy can be extremely helpful. I'll actually be leading a panel at our National Academy meeting talking about the evidence behind vestibular physical therapy, and there is very strong evidence for the therapy helping individuals prevent fall risk for more of the elderly population. And the main reason for that is because even as you're getting older, the brain is still very capable of rewiring itself, of substituting for loss of certain functions. And so suppose your vision isn't so great, well, you can retrain your brain to rely more on the inner ear, more on your position sense. Suppose you have a lot of neuropathy, which means you have numbness in the ankle, the feet, other sort of orthopedic problems. Well, the vestibular physical therapist can reweight your balance system so it focuses more on vision or focuses more on the inner ear. And so working with a trained vestibular balance physical therapist can make a big difference, and sometimes it can be the deciding factor between whether you're going to fall and sustain that hip fracture, or whether you'll be able to just continue on and enjoy your regular activities of daily living.
Great. Well, we have a couple more questions of our own, but if anyone watching has a question or a comment and you want to post it on the feed, please do so, and we'll try to answer your questions. One other question that I had wanted to ask Ted is, for example, with benign positional vertigo or Bppv, when we read textbooks about this, we get there are certain percentages of which balance canal is involved, and in my practice, it's almost always the posterior semicircular canal, which is where the crystals reside, and then when you turn a certain direction, you get dizziness. How often do we really see Bppv involving canals other than the posterior semicircular canal? Is that something that you see? How often do you have to use different maneuvers besides the Epley maneuver? And by the way, I want to point out that Ted's Epley maneuver video on our YouTube channel has almost 1 million views. The right Epley, you're almost there. That's our most popular video on our YouTube page by far. But how often do we have to use maneuvers other than the Epley maneuver, and what maneuvers are those? And then here's a question: do you ever see superior canal Bppv? Because that's something, the percentage is something small, but I don't know if I've ever seen one.
Yeah,
so it's like unicorn. Do you ever see the unicorn of the superior canal Bppv?
Yeah, that's a really great question, and very, very specific. So in the literature, it's estimated that about 90 or 95% of Bppv involves the posterior canal, and balance occurs a main part of balance occurs inside the inner ear. Inside the inner ear, you have the cochlea, which is responsible for hearing, and then you have 3 semicircular canals that are in 3 planes. There's a posterior, there's a horizontal, there's a superior. So you can think of it kind of like a gyroscope that helps you move in 3 dimensions. And out of that gyroscope, or out of those semicircular canals, the posterior canal has Bppv about 90-95% of the time, and so the maneuver called the Epley maneuver is very adequate in terms of treating that. Estimates for the horizontal canal is about 5% up to 8%, and then the superior canal, or anterior canal is also what it's called, is probably 1 or less than 1%, and it all boils down to gravity and mechanics. It's most likely that when crystals get loose and you're sitting upright, that the particles will fall, they'll slip into the posterior canal, and they'll stay there, which is why that's the most common. As far as the superior canal, gravity would make it so that even if something fell into the superior canal, most likely it would fall back out. Probably would be great if we actually had a diagram to illustrate this, but the superior canal, most likely gravity would make it fall out, and so that's extremely unlikely. I know that I was on a panel that was talking about vertigo balance disorders, and one of my colleagues said that in his 40-year history, he's seen a lot of vestibular balance patients. He doesn't think he's really seen a case of superior or anterior canal Bppv. As far as my practice, it can be a little more challenging to diagnose because the type of eye movement, so with the Bppv or with dizziness, you're looking at the eyes because the eyes tell us a lot about which canal is affected and what's going on. But the type of eye movement for superior or anterior canal Bppv tends to be downbeating. This might be getting a little bit technical, but downbeating, which can be seen with a lot of other neurologic disorders, and so that can be a little bit challenging. Mm-hmm. But as far as horizontal canal Bppv, I definitely do see that, about 5 to 8%. I think that's fairly accurate. Maneuvers that can be used to treat that include something called the log roll maneuver. There are more specialized maneuvers that were developed in France, in Italy, with the names like the Asprella, different ones that I haven't used in a while. But if you have challenging Bppv, there are vestibular physical therapists who specifically go to a course and learn about these maneuvers. They use video goggles, and so those are the individuals who would probably know those more specialized maneuvers. But I would say in my practice, the Epley and the log roll maneuver pretty much covers 99.5% of all my patients.
Great. One other question about compensation by the brain for balance problems. For example, we see vestibular neuritis or labyrinthitis where balance function is lost to a particular degree in one inner ear, or for example, the removal of a tumor on the balance nerve that would cause a loss of balance function. Are there patients that do not compensate? In other words, normally the process is that the brain will adapt to the loss of balance function in one inner ear over time with exercises, activity, and therapy. Are there patients who actually cannot compensate? Are there people that get to a point where they just cannot fully adjust for the loss of balance function in one ear? Do you see patients who do not compensate? And if not, why don't they compensate?
Yeah, so I see a large, definitely probably a large number of patients who don't compensate from their unilateral or one-sided weakness. And we don't always know specifically what's going on neurologically, because we know the process of compensation involves some neurologic remodeling in the brain, that the brain is in effect rewiring itself, relying less on inner ear function and maybe depending more on the neck, more on the visual system, perhaps more on the opposite inner ear. So as far as compensation, I would say that individuals you could say that they fall into two main categories, and these categories can overlap. And so there are individuals where after a weakness to the inner ear, somehow they still have that weakness. And usually what they experience is, so for example, if somebody has an acoustic neuroma removed on the left side, they have a weakness. Typically what they would immediately experience is they would immediately experience vertigo. They would sense the room spinning, and then say after 4 or 6 weeks they would start to notice that head turns to the affected side, in this case left acoustic neuroma turning to the left. The things are just visually unstable, while turns to the right side are more stable. And so that's the primary form of compensation, where the brain augments something called the Vestibulo-Ocular Reflex. That's the reflex between the inner ear and the eyes. And so there are individuals who don't compensate in that regard. And it's not clear why. We definitely know that individuals who have other neurologic problems, who are on medications like Valium, antihistamines, sometimes that can hinder compensation. But then there's a subset of patients where we don't really know why they don't compensate. And so that's kind of one group of patient. The other group of patients are individuals who do have inner ear compensation, where their vestibulo-ocular reflex does settle down. In other words, once again, using the left acoustic neuroma patient example, they turn to the left, things are stable. They turn to the right, things are stable. However, they don't compensate in another way. They develop kind of a constant dizzy unsteadiness. They become extremely sensitive in grocery stores, can't tolerate computer screens. They feel better when they're lying flat. And this is another phenomenon, something that we're starting to recognize more, a type of dizziness called persistent postural perceptual dizziness, or 3PD. And that's another route that individuals can go, and some individuals can have an overlap between the two. But we don't specifically know why in an individual this compensation mechanism doesn't click in, especially if we rule out medications or other medical problems that might be hindering that process.
Yeah, thank you. That helps a lot. One other interesting disorder that many people have been through is mal de débarquement, which is the disorder of getting off of a ship after a cruise or after a train ride or an airplane ride and feeling that persistent rocking or that persistent motion sensation, vertigo sensation for a period of time. Do we know why people get that phenomenon? Do we know, other than time and therapy, is there anything else that makes that get better more quickly? And also, just one other question is, how many people actually experience that?
That's a really great question as far as the epidemiology, or how many people experience that. I don't remember offhand what the statistics are on that. I would say in general that is probably one of the less common types of dizziness I see in my practice. Definitely less than 5%, maybe even like 1 or 2%. And it has a very specific diagnostic criteria. So it starts off after being on a cruise, on an airplane flight, some sort of situation where you're constantly moving, rocking, and the brain has to compensate. And so I'm sure many of you who may have been on boats or cruises know that the first few hours, the first few days, you get seasick, you get nauseous, and it takes you a while in order to get your sea legs. Well, what mal de débarquement is essentially your brain forgetting how to get back to its normal state after having attained your sea legs. And it's not clear why that occurs, because it doesn't necessarily occur after every cruise. It doesn't even necessarily have to be an extremely bumpy cruise. Some evidence shows that individuals with history of migraine headache, in other words, with migraines you're more hypersensitive, tend to have more motion sickness, may be more susceptible to mal de débarquement. And by definition, it's this constant rocking, swaying that's there at least for a month. Because for most individuals, it's not uncommon to have that for 1 to 2 days after your initial travel, your initial cruise. Interestingly, this rocking, swaying is there 24/7. It doesn't settle down when you're lying flat. It doesn't improve when you're walking around, when you're sitting. Position doesn't make a difference. Many individuals state that when they're riding in a car and things are passing by, that's when they feel the most stable. Unfortunately, the prognosis for mal de débarquement is not necessarily that great, in that there are no consistent effective treatments, but there are many treatments on the horizon. Sometimes medications can help, like a low dose of a SSRI or SNRI like Effexor, venlafaxine, Lexapro. Physical therapy can be helpful, although there really isn't as consistent evidence. Some research is being done in transcranial magnetic stimulation, where essentially they put an MRI magnet to your brain and try to reset things that way. There's some research in New York that's talking about a certain type of therapy that might help, but results are really all across the board. The other thing to realize too is many dizziness disorders resemble mal de débarquement, except you may have not had a original cruise or travel that triggered the symptoms, or perhaps the symptoms settle down where you're lying flat. Just know that mal de débarquement has a very strict diagnostic criteria. There are a lot of dizziness entities that resemble it. So just make sure you're not diagnosed with mal de débarquement unless you really have it, because prognosis it can be a very difficult disorder.
Yeah, thank you. And I think it's also just interesting to comment at this point that many balance and vestibular disorders that after we go through diagnosis and we're doing treatment, there are very few FDA-approved therapies for many of these problems. And so when we discuss using certain medications for these disorders, we're talking about off-label use of medications, which in the specialty of otolaryngology, particularly in ear disease, for example, Meniere's disease, I think there are no FDA-approved medical therapies for Meniere's disease. So we're talking about off-label use. Just as an aside, I think it's interesting to mention that, because this area of overlapping disorders, and you mentioned anxiety disorders, there is a big overlap between anxiety disorders, sensitivity of the brain and central nervous system to different stimuli, such as a cruise, or in other problems that may reside in the inner ear. And so you're dealing with overlapping entities, and that often requires, this is an area of art of medicine. I mean, this is really an area where it's an overlap between scientific diagnosis and then use of clinically tried things for these things, but also you're trying to pull out and extract from what you know what things might help a particular patient. And there is good literature on many of these things, but it's interesting to comment that many of them, we don't have a lot of FDA-approved therapies for these problems.
Yeah, I mean, I absolutely agree, and part of it may be it's just very difficult to, when somebody's coming in with dizziness and suffering, and there are some treatments that are already in use. It's hard to, I guess, tell a patient that we know that this has a high chance of working, but then let's try this clinical trial to try this other medication. And I think you bring up a really great point, Eric, that in all of medicine, but particularly with patients with dizziness and balance disorders, the art of medicine is really important. The bedside manner, the history. In one of the talks I give on the persistent postural perceptual dizziness, I kind of go back to the fundamentals of medicine, what we're taught in medical school, that when a patient comes to you, they come to you with symptoms. And as physicians, we're trained to try to tie symptoms into a particular disease entity. And often we can do that, but sometimes we can't. But we also know that symptoms are affected by many other things. Symptoms can be heightened by anxiety and other psychiatric factors. Symptoms can be physiologic. There's a fight or flight response. When a bear runs towards you, you're going to have sweating, you're going to have palpitations, you may have to go to the bathroom, and many patients come to me with those symptoms, and I explain to them that in and of itself is not a disease, it's the body's normal response to that type of situation. And then the final thing that affects symptoms are things that social factors, pressures from work, disability, medical, legal. Even though an individual may not be deliberately trying to malinger or get government benefits, what often happens is an individual is not well, they get some benefits, and even though they're not in a great place, it's hard to change, and it's kind of scary to change, to risk going back to work and losing some of the benefits. And so that's something you always have to consider and counsel and really think of more of a holistic approach to the patient.
Thanks, Ted. Yeah, I think, and that brings up a couple thoughts. One is just multidisciplinary management, bringing in a lot of different specialists to help out. I want to go back to something you mentioned before. You mentioned that you're going to be speaking at a panel, but one of the things you mentioned was fall prevention, and this is such a huge area as the population ages. The morbidity of falls, fractures, hospital stays, getting hit in the head, subdural hematomas. There's a huge, sequelae of falls, and the medical costs and morbidities that go along with them. What are the things for patients that we can do to help prevent falls? What goes into a fall prevention program? What kind of therapies do you do for them other than physical therapy? Are there other things? And I guess one other question I have is, just as an aside, is, are there any trials on the horizon for medications to directly work on the brain part of balance? Is there anything that coming down the pipe that will actually go towards the brain aspects of coordination or the cerebellum or something in the balance system that we're going to be able to use for patients other than therapy to help them to do better, especially as they get older?
Yeah, a really great question. A lot of different layers to that question. So last year I was on a panel for fall prevention at our academy, and as Eric says, falls are going to continue to be an increasing problem in our society as our baby boomers age, as more people go up to age 60, 70, where the rate of falls and dizziness and balance issues significantly increases. And so I would say probably the most important thing to know about to teach about fall prevention is just basic awareness, not only to individuals in the community, but especially to primary care doctors, because chances are if an older individual is at increased fall risk, they may not necessarily go to a specialty balance center. They're probably going to see their primary care doctor, and some of the most common very basic measures to take are checking your medication list, making sure you're not on excess medications, because the term is polypharmacy when you're on 4 or more medications. That's a significant risk for increased fall. Other things are how your house is laid out. Do you have rugs that you can slip on? Do you have coffee tables that you can trip over? I mean, some very practical interventions that can try to help reduce the risk of falls. Fall prevention and management is definitely something that is a very high health priority in the United States for our National Institutes of Health, and there are some trials being done just in terms of the natural course of falls and the benefit of physical therapy. And so there are definitely a lot of things on the horizon. I know that I can't remember the website, but I had it in my talk. There's a website that talks about how to set up a fall prevention program that's set up by the government. There are brochures and pamphlets, easy ways of testing, particularly for primary care physicians. Now, the second part of your question about medications to increase or augment balance function, it's kind of interesting because when you look at different medications that are used for dizziness and balance disorders, I would say for the most part, medications focus on suppressing hyperfunctioning of the balance system. In other words, suppressing that rocking, suppressing that spinning sensation, suppressing the nausea and vomiting. And medications are not as great at augmenting. So if somebody already has some weakness or hyperfunction, there aren't really many great medications. And at this point, I'm not really aware of any medications on the horizon. Now, one medication that's been used for a while that there's been some evidence out of Europe that may help in augmenting function is a medication called beta-histine. It's a type of antihistamine that's more centrally acting. It acts more on the brain, so it's not like Benadryl or Claritin. And it's also used in Meniere's disease, particularly in overseas in Europe and Asia, South America. And there's some evidence that the histamine receptors in the brain can be stimulated by beta-histine, which will augment blood flow and also aid in vestibular compensation, specifically at the level of the vestibular nucleus, which is in the brainstem.
Well, Ted, thanks a lot for participating with us today. Believe it or not, we've been going for almost 45 minutes, and I think that's probably a good place to call it for today. I don't see any other comments or questions right now, but I want to just let you know, thank you, and we appreciate your time and coming to talk with us today. I'm sure we'll have you back soon for another HEI Live, and thanks a lot for coming.
Yeah, thank you.
Okay, thanks a lot. We'll see you.